You ready? Okay, welcome to the Laguna Honda Joint Conference Committee for March, and we'll proceed to call the roll.
Yes, sir. We'll start with Commissioner Green
Present.
and Commissioner Chow.
Present.
I will read, thank you. I'll read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. The second item on the meeting agenda is the approval of the minutes of the February 13, 2024 meeting.
So the minutes are before us. A motion for acceptance?
Move to approve.
And I would second. Is there public comment?
There indeed is. I will note that we have only one person who's received accommodation for public comment today. So unless they're in the room, we will only have that one person. Caller, I'm about to unmute you. Caller, you've got 3 minutes.
2024 Health Commissioners failed to ask any questions at all about data in the January Regulatory Affairs Report. Of the 15 FTAG violations in December, 13 of the 15 involved the same FTAGs that LHH was cited for during the RCA Report Number 1, involving 8 CDPH inspection surveys conducted between October 14, 2021 and April 14, 2022 when LHH was decertified, as well as FTAG violations LHH was slapped with during its first 90-day monitoring survey in December 2022. Why does LHH continue racking up 13 additional recurring FTAG citations that happened over 2 years ago? LHH has had 2 full years to put corrective actions into place, but is still getting hit with 3 different types of care plan violations, disease prevention and control findings, accident hazards, and worst of all, failure to report violations in a timely manner, if at all, to CDPH. Since the Christopher Cherney expert witness declaration filed in the Tommy Thompson lawsuit came to the conclusion this health commission has failed to adequately perform your governing body oversight duties, and also concluded those governing body failures resulted in excessive costs on external consultants that amount to a breach of the LHH governing board's fiduciary duty to act in LHH's best financial interest. Don't you agree, commissioners, that you should start asking the kinds of questions I raise above about the data being presented to you in the regulatory affairs reports? After all, when you do not ask these kinds of questions during health commission meetings, it sends a clear message to members of the public that you are not performing your job duties very well, and would flunk a job performance review if there were actually a performance review of how well, or how poorly, you're doing your job to provide oversight of Laguna Honda Hospital. Thank you.
Okay, that's the only public comment.
All right, so we're prepared for the vote. All those in favor, please say aye. Aye.
Aye.
Great, thank you so much. We can move on to general public comment. Item 3. There's no one in the room. Do we have any remote? Yes, we've got a hand. Give me 1 second to clear the clock. Caller, you've got 3 minutes.
This is Patrick again. This public comment does not involve an item on today's agenda. Don't cut me off. All members of this health commission should read a comment posted online by a current anonymous LHH employee in response just below Dr. Kerr's and Dr. Rivero's recent Westside Observer published article. I'll send Mr. Morwitz the hyperlink for him to forward to you. The employee notes a problem with the veracity of NSAG's consultant, Julie Klein, who had been assigned the role of being LHH's nursing home administrator, and additional information about assistant nursing home administrator Dilter Sidhu hired at LHH. NEC's online comment may help end LHH's culture of silence brought on by LHH's former CEO Mivek Hirose. Observers like me have waited a long time to see signs Hirose's culture of silence comes to a stop, with employees willing to speak truth to power as letter writer NEC has done. Bravo to them. The health commissioners should also read both Dr. Kerr's article and the 2 comments I also posted in response, also below his article. Thank goodness there are still brave LHH employees willing to speak out, as Nisi did, however anonymously. Their remarks should receive a whistleblower shout-out. After all, there's nothing like having a reliable insider express their insights. One reasonable question is whether LHH and the city were overcharged to provide an NHA expert consultant familiar with skilled nursing regulations, but the city then wound up getting a run-of-the-mill assisted living facility style administrator, Ms. Klein. And whether that reduced proficiency level experience contributed to LHH tripling the number of citations it has received, delaying recertification. Dilter Sadhu, LHH's assistant ANHA for support services, serving alongside Jennifer Cartonwaite as an AHNA for care experience, had been the NHA at Fircrest Convalescent Home in Sebastopol when CMS/CDPH decertified this facility. The Fircrest 50-bed facility eventually closed completely, according to a February 2018 Press Democrat article. This bodes ill for the future of Laguna Honda. Thank you.
That is the only public comment for this item, so we can move on.
Yes, please.
If I may, we can move on to item 4, the executive team report, and I will pull up the presentation. Please just give me a moment. Okay, good to go.
Good afternoon, Commissioners. Roland Pickens, Director of the San Francisco Health Network and Incident Executive Sponsor of Incident Command for Laguna Honda Recertification. I'm joined here in the room by Laguna Honda CEO and Nursing Home Administrator Sandra Simon. And we also have joining us remotely several members of the leadership and executive team of Laguna for today's JCC. It's our pleasure to present you with this month's report. First slide. Oh, okay. Okay, you'll have to. Okay. So as we've shared previously, Laguna Honda completed the reasonable assurance period for the second Medicare recertification survey back in December. The survey results showed improvement from prior CMS monitoring surveys with overall less findings and findings of lower scope and severity. The Laguna Honda team has developed robust plans of correction from that survey with our quality improvement expert health services advisory group in response to the survey results. Accordingly, the fire life safety portion plan of correction was submitted on January 13th, and the health monitoring portion was submitted on Wednesday, January the 17th. Next slide. It's important to remember that at this time, Laguna Honda is not yet recertified in the Medicare program. The next step is for CMS and CDPH to approve the previously submitted plans of correction. Subsequently, CMS and CDPH will then validate the successful completion of their approved plans of correction. And then finally, CMS will make a determination of Laguna Honda's reentrance into the Medicare program. As you know, regulators from CDPH and/or CMS are often on site at Laguna to resolve both facility-reported incidents and anonymous complaints, which is a common practice across all skilled nursing facilities and a requirement in terms of facility-reported incidents. Laguna Honda takes the process of reporting unusual occurrences and allegations of abuse very seriously. In fact, all staff are mandated reporters who regularly receive training on the topic. The directive and instructions to report are carried with all staff every day on their employee badges. We also take seriously the process of working with regulators when they are on site to investigate facility-reported incidents and anonymous complaints and providing those regulators with relevant documentation. To that end, on yesterday, March 11th, Laguna Honda received 2 what are referred to as 2567s, statements of deficiency. 1 was for an anonymous complaint, and 1 was for a facility reported incident. In those 2 2567s, regulators identified 3 deficiencies between the 2 2567s. Because those were received just on yesterday, the details of those will be contained in the regulatory affairs report for the next JCC. Rest assured, Laguna Honda is well underway, which is where Ms. Simon was prior to coming here today, in developing the corrective action plans for those 2 2567s, and have drafted their initial response and are required to submit those plans of correction by the deadline of March 21st. We anticipate that Laguna will need to complete the 2567 submission and validation process before CMS will make a final decision on the Laguna Honda recertification process into the Medicare program. Next slide. We would also like to share with you the status of discharging residents at Laguna who no longer have need for skilled nursing level of care. The team at Laguna actively works to discharge residents who no longer require skilled nursing care. And as you recall, in March of last year, we were directed by the Federal Department of Health and Human Services to do just that, to move forward to discharge those residents. As you might imagine, some of these residents have very challenging situations, and there are oftentimes barriers that present themselves that prevent a timely discharge process. Since initiating those discharges in April of last year, so far Laguna has discharged 22 of those non-skilled nursing level of care residents. Currently, there are a total of 44 residents residing at Laguna who fall into this category of no longer needing skilled nursing level of care. Next slide. And as we prepare to close this formal presentation, we're presenting you with our normal slide of pertinent statistics for Laguna. You'll see from the period displayed here, December of 2022 through February of this year, there were a total of 21 planned discharges, 5 unplanned discharges, and 70 expirations. And of course, no new admissions due to the prohibition of admissions due to the CMS recertification issue. In terms of admissions to Laguna Honda, I'd like to share that the team at Laguna has worked hard to refine its admissions process and policies and procedures, including its outreach to, and its strategy to communicate with the former Laguna Honda residents who were transferred to other skilled nursing facilities. Once recertification is achieved, Laguna Honda will move forward very quickly to incorporate any relevant feedback CMS gives into its admissions policies so that that can inform the admissions process as we welcome back. First, the priority is those former residents who were transferred. They are the priority group 1. And then once they are sufficiently returned, we will open up admissions to other new referrals. The admissions procedures, including the outreach plan to those former residents, will then be presented to the JCC as soon as we have the final feedback from CMS on our recertification plans. So that concludes my presentation, and myself and the team are happy to take questions or comments.
Is there any public comment?
There is. Give me 1 second to pull up another set of slides or another slide. Let's see. Caller, I've unmuted you. I'm about to share your slide. When the slide shows, you may begin your comments and I'll start the clock. You go now, please.
Mr. Morwitz. This March 12, 2024 executive team report wrongly states on page 2, quote, survey results showed improvement from prior CMS monitoring surveys with overall less findings and findings of lower scope and severity. End quote. That's untrue. As my attached draft data analysis chart illustrates, LHH received 62 citations between 2019 and 2022 that led to LHH's April 14, 2022 decertification. Since then, during official survey inspections, LHH racked up a total of 171 additional citations after decertification. So, citations have tripled. As for the severity ratings, LHH received 5 immediate jeopardies before decertification and earned another 5 IJs after decertification. The level 3 actual harm citations increased from 5 before decertification to 7 after decertification. Level 2 potential for harm citations more than doubled, from 52 before decertification to 123 after decertification. Following ending of the 3 mandatory formal 90-day monitoring surveys, so-called abbreviated complaint surveys keep yielding almost as many citations as the 3rd 90-day monitoring survey. The sheer volume of 171 more citations after HSAG was brought on board 2 years ago in May 2022, after being awarded $24.3 million so far in non-QA contracts to get LHH into regulatory compliance, suggests that compliance hasn't happened yet, now 24 months into SAG's multiple contracts. That in turn suggests these very expensive consultants may have been unqualified to correct improper and substandard patient care practices. The stalled resumption of admissions may be due to deficiencies in management practices and structure that also haven't been corrected. Also on page 2, Pickens reports the 2 plans of correction were submitted in January 13, 2024 and January 17, 2024, respectively, but those survey inspections ended on December 1, 2023 and December 7, 2023. Why did it take LHH a month and a half following the end of each survey inspection to write and submit the plans of correction? It's outrageous another 2 months have slipped by without CMS accepting the plans of correction or even asking for revisions to them. Thank you.
All right, I can stop sharing. And commissioners, that's the only public comment for this item.
Okay, great. Thank you very much, Mr. Pickens, for your report. Commissioner Green.
Yes, yeah, thank you. I guess I had 3 questions. The first is, you talked about the barriers to transferring individuals that no longer qualify out. And I wonder if you could, in the public forum, elaborate as to what some of those are, because I quickly reviewed, the answers to your questions, and I had no idea, for example, about the extreme difficulty in finding out placement in terms of the actual, not only availability of places, but their staffing. Can you elaborate on that in the public forum so people have a better idea?
Sure, I'll try, and if I miss anything, I'll ask my colleagues to help. So I think it's important. So I think it's a tale of 2 cities. As I mentioned, there have been 22 residents that have been discharged since April of last year. And I think, and there are 44 that remain. Those 22, I think, represent the cases that had the least amount of barriers. Even though all of these, because they are no longer skilled nursing, present barriers because there are limited placements in the community for them. But those 22 that have gone were actually the easier of the difficult cases. We're now at a point where the ones who are left are the ones that are even more challenging in terms of what their needs are and beds within the community that can match those needs. Some of those barriers range from needing to secure durable medical equipment, have it installed either at the board and care or wherever their destination is. And obviously, we don't do those processes ourselves, so there are third parties involved who need to go in, install those items, secure them, and sometimes there can be delays. They may say it'll be ready on a certain date, and it could be a month later before it's actually ready. Other barriers, and a big one, is the fact that rightfully so, all of these residents have appeal rights. And while we have determined based upon the criteria set forth by Medi-Cal that they no longer meet skilled nursing and have needs, they may disagree and therefore appeal that process. So that is a further delay. In addition, most of those residents, 44 who are still on that list, are requiring placement in board and cares. As we know, the number of board and care homes within the community has decreased significantly over the last 5 and 10 years. But also importantly is if a resident who requires placement in a board and care, again, does not agree with that placement, they don't have to sign the referral packet that is a regulatory requirement by the state of the board and care. So we're caught in this situation where we cannot even refer that resident to the board and care if they don't sign the packet, because the board and care would be in violation of state rules if they received it and tried to process it. So those are some of the examples of barriers, and there are even more.
Yeah, it sounds like residents who are conserved often have an additional assessment by an external entity that can take up to 3 months.
That is correct, yes. So some of our residents are covered by the county conservatorship process, and they have a companion process for their review and or approval of those discharges.
Well, I really appreciate you articulating that, because in the same way that we're kind of, I hate to say hostage to CMS, but we really are at their mercy in terms of when they decide to respond to what we submit. It's a similar thing with this, that, you know, you're doing everything you can, and yet you reach these barriers where there are only so many ways you can surmount them. So I appreciate your elaborating on that. The second thing I wondered is whether, you know, you talk about CMS looking at our readmission plan, and I grant that you know, we have much more complex residents that we accept than many other skilled nursing facilities. But I had 2 questions. First of all, does CMS offer any kind of template for admissions? I mean, it may not be as elaborate as what we need, but is there anything we can refer to that would guarantee that we would check all the boxes they would expect on our admissions stipulations? And then the other question is, it sounds, if I heard you right, that not only have we worked on this, that we're just ready to go. And I wondered whether, if there are any policies, whether it would be another policy approval that needs to come through the JCC and then the Health Commission that might slow things. So I'm just wondering how we can institute immediately, because it may be next week we find out we can admit, we don't know. And obviously you have to, there's a lot more involved. It's one thing to have the theory, it's another thing to actually operationalize it. But I'm just wondering how we're going to be able to ensure that it will be accepted and that we can move quickly, as you said, once it's done.
Sure. So I'll take a stab at the second part of the question, then I'll ask Director Simon to talk about the first part in terms of templates or guidelines. So the good news is we have been working hard on the admissions process, and we do have a draft plan. And again, it's draft because we know that in our plan of correction that CMS has yet to reply to, they may very well put in requirements related to admissions. And so it would be premature for us to actually do that until we get that response. However, we're not waiting. All of the, as you know, many policies, procedures related to admissions have come before the JCC over the last 6 months. Those have been informed by all of our current best thinking in terms of our preparation for these new admissions. So right now, based upon what we know, we would be almost ready to go, but knowing that there's still this one outstanding piece from CMS, we want to make sure we incorporate that to then inform, do we need to come back to you with changes, say, to the admissions policy you just approved in December? It's just a little too early to know the answer to that question. So in terms of Medicare or CMS templates related to admissions, I'll let the expert in skilled nursing answer that question.
Hi, good afternoon. Just to restate the question, you're asking if CMS has a template for admissions process?
Well, I was, we already approved admissions policies, and so it's been mentioned that maybe CMS will want refinement or more information or more detail. And I was just wondering if there's anything we can look at to make sure that if there are additional things we need to do because there's a CMS template for it or CMS list for it, that we can pre-approve those things so that because there is a delay between the JCC and the commission. And I would hate to see, the work delayed because of some, really bureaucratic technicality and that we have to approve policies. Or do you think the baseline of what we have, even if there are a few tweaks, that that's adequate so that an approval from this body will not create barriers?
Right, no, the baseline is adequate and CMS isn't going to give you a template. They would refer, basically the overall direction and through regulation would be that you have to ensure you have proper screening tools, that you do your due diligence upon admission, ensuring that you can, not only does the resident need and require skilled nursing level of care, but that you are able to care for them. And there are many ways for you to assess whether you can adequately care for that, for the resident you're accepting, because there are many different diagnoses and treatments that you can provide. Some nursing homes do all of them and some only do a very small, they specialize in a very small niche, and they will, although they may get referrals for people for admission that could require, they would deny them because they don't provide that service. Where another one with the same licensure could admit because they do provide that level of service. So there are, it's kind of a complicated answer. There's no set template other than ensuring that you provide, that they need skilled nursing, that the services you provide, that you are able to provide them adequately. Does that answer the
That helps a
question?
lot. And
Okay.
based on your past experience as a chief SNF administrator, do you feel confident and comfortable that we have an adequate policy in place as is so that changes or tweaks will not create barriers?
I don't think that will create, I think we have, but I'm confident in what we have and there will not be any barriers.
Great. Thank you. That's what I wanted to know.
Okay, thank you.
So Mr. Pickens, I'm wondering if we could go through a little bit the chronology of what has happened since the Medicare survey, because it isn't just that it went to Medicare, right? And if I recall in your past testimony, it'd be good for us to
Sure.
kind of recollect. It actually has a stopover at the state, and then
That is
the
correct.
state is the one who really submits their comments and
Yes.
and then where we are then in terms of, because the survey occurred, in November, December, right?
Yes, yes. So I'll try to remember this off the cuff. So yes, late November, early December, the survey concluded. And while the survey concluded, you'll recall, it's not official until we receive the 2567 from the state. And that receipt happened several weeks after the survey concluded. So when one says, well, why did Laguna wait until January 13th or 17th? It's because we received the 2567 10 days before those dates, and we're required to submit it within 10 days. So we weren't sitting on our hands. We were waiting on the official notice of the survey results. Then once we submitted those plans of correction, they first went to California Department of Public Health for their review and feedback, which they did and gave to us. Subsequent to that, then it left California Department of Public Health and went to CMS for their review and feedback, which is where it remains at this point.
So when we went to California with it and they came back with some comments, how long did they, how long was it before we then resubmitted the comments to DPH and they then felt that it was sufficient to send to Medicare so that we would kind of get a feeling as to when it got to Medicare?
Yes, so we, given the criticality of this whole situation, turned around our response within a week back to CDPH.
Okay, and do we know the date that CDPH sent to Medicare?
No, unfortunately, we don't have that detail.
Okay, but would we have a feeling of course, it's after January 17th, and it was a week later that we then, well, they would take some time to review.
It took them
So,
a couple of weeks before they got back to us. And so
okay, so like it's about 2 weeks. I'm just trying to figure
Yeah.
out about when. So somewhere around the early part of February,
that would,
the state
yes,
then submitted the corrected CDPH, I mean, our corrected POC to Medicare.
that,
And
they-
therefore, we're waiting for Medicare over a month rather than 2 months because it just didn't go directly to Medicare. I think that's important for us to realize that there are really intermediate steps.
yes.
And so I appreciate that sort of refresher because I think we kind of forget. I mean, kind of looks like, okay, we got this report and therefore it looked like we were directly dealing with Medicare. But I was educated in your presentation earlier, several weeks earlier, that that wasn't the case. And I just thought it would be good to reemphasize for us that it's probably about a month that we're waiting for Medicare's response, right?
Correct.
Very good. Thank you. In reference to the 2567s, I think you were commenting that you thought that Medicare would not actually give us a response until these two were answered, but are there not certain other findings from the past reviewers that have over the last several months taken place? I mean, in terms of they're much quicker response on our fries and they have then, and we have submitted corrective action plans, right? So what would these two be special, or you're just indicating that all the fries, they may want to really see how well we're doing as part of their review?
Correct. It's the latter. They've made it clear to us throughout the whole process. Recertification won't happen until we essentially have a clean slate. And in their minds, with these two open 2567s, they'll need to see some resolution to their satisfaction that we can deliver the safe, regulatory, compliant care and address those three deficiencies that they identified. And so the thought is to be consistent with what they've communicated all along, which is remember why they cleared out all those hundreds of old fries. They said in order for them to have assurance that we are okay to be back in the program, they needed to resolve any open outstanding cases. And now we have these two.
Okay. So that's why, because we've closed the others in
Yes.
this interim period
Correct.
of even the 2 months that we've been waiting. And they, for the most part, seem to be closed with satisfaction.
Correct.
And the public gave us a very nice chart, which I thought actually helped demonstrate how well you have all been doing. As I recall, it's really the last survey that really is important. And the trend that you have been telling us is really demonstrated here, where there are fewer and fewer of a certain level. And it isn't so much the addition or the sum of all these, but what, and as a survey, I know that, right? It's dependent upon the last survey, what you pass.
Correct.
And no survey passes, goes through with no findings.
That's been
Eh,
my experience the last
Yeah.
30 years.
Yeah, I do recall Chinese, I think, came up with just about like 3 or 4, and that was just, but they're a much more tinier facility. But I mean, we don't ever expect a survey. I mean, it's just like the Joint Commission survey at General. We always expect that there will be some sort of ability to improve ourselves.
That is correct.
And the severity of that is really what the issue is, right? And we've been watching for F tags all the way up to the grade to L, right?
Yes.
And you've actually accomplished in your last survey having none of those.
That is correct.
And I note that you are in the process of correcting a lot of the others, and yet, as you pointed out, there are fewer results, fewer issues that were raised at each of our surveys with Medicare. So now you're saying that one thing that will hold us up is that they want to know how we are doing with these plans of corrections on anything that they find. And of
Correct.
course, we're going to have continued issues of reporting. people are going to fall, and we try as best. I think our fall rate, while not satisfactory, is still below, is it not, the national average on your on the Casper report?
We, Nas can tell us. I think she probably has that information, and she's on the line. She may be able to comment.
I think it'd be important to understand where we are with falls. Just
Nazar, if you're there, can you jump in?
okay.
I'm sorry.
We
That's
have
like
the
Commissioner
Casper
looking at.
report here, and right in a comparative, we're actually about 12th in the country on the low side versus right, and it continues to be that. And on a comparative group with the state, even we're 1% below. And so it's admirable that we all are continuing, well, as we should, to work on it. I mean, one fall is one fall too many, as we know. So I do think that the trend that you're showing and the levels of care that we are giving are, with the demonstration of less deficiencies, really does show. And I think that was you've answered the questions in regards to uh, the thoughts right now of the admission policies and the people who are going to be involved in it, and based upon what we have passed right on the admissions. And I'm glad you've also then been able to tell us that in this draft, the priority one will be the people who were sent out and be given the opportunity. So appreciate that. I think these are important clarifications for all of us as we get asked these by different people. Commissioner Green, any other questions to the executive team here? We'd like to see, I would like to see the rest of the team now that we're able to sort of meet in person, but really appreciate the work they're all doing. So, and I think the different surveys have shown this a very remarkable improvement on your part. So thank you.
Thank you.
Shall we go on to our next question?
Yes, sir.
Next item.
Item 5 is the hiring and vacancy report.
Who's going to give that?
Sherry is teeing up.
So, sorry, my camera looks a little bit odd. My name is Sherry Suto, and I'm a principal HR analyst filling in for Priya Nayar, the HR operations manager at Laguna Honda, who's out of the office. Let me see. So, Laguna Honda vacancies decreased in February to 9.6% from 13.9% in January. We've hired a total of 25 employees between February 1st and February 28th, 2024 in various classifications, and had 4 separations during the same period, with 4 of those non-retirements. The RN vacancy rate decreased to 2.8% in February from 7.69% in January. We have 6.0 FTE to fill, and they are scheduled to be filled this month, March 2024. To mitigate challenges in hiring nurses, over the last 60 days, the nursing leadership, in collaboration with HR, conducted an expedited hiring project to fill RN vacancies. Hiring managers have made over 100 selections to fill vacancies DPH-wide. The anticipated start work dates are in February and March. HR is holding RN onboarding events starting on February 23rd, 2024 for all new hires. An RN open house / info session is being planned within the next couple of months. Nursing leadership and HR have developed a strategic hiring plan and timeline for continuous RN hiring. HR also conducts regular vacancy meetings with program and hiring managers to review hiring. Some RN highlights: 2 2320s appointed in February, 4 P103s appointed in February. 6 2320s are targeted to start in March. Non-RN hiring highlights: 36 2303 CNAs have been selected and are in the onboarding process. 10932 Laguna Honda Director of Emergency Management and Disaster Preparedness appointed in March. 12322 Nurse Manager appointed in March. 19 2312 LVNs were selected and targeted to start in March. 12230 Physician Specialist appointed in February. 67334 stationary engineers have been selected, and 2 are targeted to start in March. And finally, 16138 industrial hygienist has been selected and is in the onboarding process. That's it for the HR report out.
Thank you. Thank you. Is there any public comment?
Yes, of course, we've got a hand up. You're unmuted, caller. Please let us know that you're there, and you've got 3 minutes.
Report for this March 12th, 2024 LHH JCC meeting states LHH total vacancies were 11.7% in February, down from 12.8% in January. But today's separate 4-page vacancy report by FTE report shows LHH's total vacancy rate is 9.6%. Why are 2 different reports presenting different data and timeframes? The vacancy report by FTE report presented February 14, 2024 was actually the December 2023 report. Was the January report was never presented to this JCC? Tracking these reports is like comparing apples to oranges. The 7,334 stationary engineers were identified last June as being critically needed. What took so long to fill them positions? Why is hiring for 23 vacant home health aide positions been on hold for February and March? When will that hold be released? The summary report says 19 class 2312 LVNs would start in March, but the FTE vacancy report says there are only 10 vacancies. The summary report says 36 #2303 certified nursing assistants are in the onboarding process, but the March vacancy report by FTE, which calls them patient care assistants, says there are only 23 vacancies. Why are there disconnects between the 2 reports presenting both different data and different job titles? The Human Resources Summary Report presented in February indicated a job class 0943, presumably of manager Roman numeral 8, with a working title of Chief Care Experience Officer. That job class is the same job classification as Sandra Simon hired as LHH's CEO and nursing home administrator. Why does LHH need a 0943 Care Experience Officer in addition to Jennifer Carton-Wade, who was hired as a job classification code 0941 manager Roman numeral 6 with a working title of Assistant Nursing Home Administrator, Care Experience? Why does LHH need both a 0943 and a 0941 manager in charge of Care Experience? Does that duplicate duties across the 2 positions? Strangely, the December vacancy report by FTE report, with a run date ending December 1st, 2023, indicated there were no vacancies in job code 0943. So how could that new hire have started in January 2024? Thank you.
That is the only public comment for this item.
Thank you, Commissioner Green.
Yes, thank you for the report. And we have before us March, so we don't have February. But, I did have one curiosity, and I did send a question in. Some of these positions on hold are actually positions that are being eliminated, maybe because our census is down. And I wonder if in the future we can have some clarification about, which positions are, I think there was also a managerial position, 3 vacant nurse manager positions that were going to be cut. So I'm wondering, as we try to get an overall picture, whether we can both sync up the reports, but also get a better sense for, because on hold makes me nervous. If we need all these people and they're on hold and they're 37%, maybe, you're changing the way residents are being cared for, or you're changing the teams. But it would be helpful to know, especially if positions are on hold because they're being eliminated for the moment, what the rationale is and how we're feeling. I mean, that's just an example where it seems like a lot of vacancies, and yet I don't know what exactly, whether all the residents need home health aides or not, but it would be helpful to get more clarity on some of those things.
Oh, I'm sorry.
Yeah, thank you for the question. I think what we will need to do is work with our human resource leadership to do just as you said, try and reconcile and give some greater detail in terms of some of these recruitments and how it may relate to the budget and other current initiatives that are going on simultaneously with the regular recruitment process. For example, in like the nurse managers and the home health aides, there are additional details. I think we can do a better job of explaining that to you.
That would be great, because I know, obviously Laguna, like everything else in the city, is going to face some budget cuts on the one hand. On the other hand, we do have fewer residents for the moment. And so I think it would help to understand, so that, obviously there's a lot of creative thinking going on about how to manage residents with best practices, all to the good. And it would be interesting to know how your thinking correlates with the way staffing is shifting and so forth, including the way you've already changed, the 2-tower idea with the key nurse manager. So obviously there's a lot of thinking going on. It'd be helpful to relate that back to these reports, and then also understand the time frame, because it's still early March, so it's confusing that you get a March report and how it all works with February, March. So that'd be great. We'd really be interested in hearing more in the next meeting.
I am looking at your LHH vacancy rate graph, and so I think there is a question here, because it appears that we are putting in a March vacancy rate of 9.6%, whereas it's actually a February. So I think we have to sort of decide where we are putting these points. Did you see that? Am I misreading that?
I just gave him the report, Commissioner, so give him a second.
Sure.
to-
It's on the last page of the
I see
packet.
where you actually see a data point for March. Is that-
Yes. The data point for March, I mean, you've reported really fine that the February is at 9.6%. So I'm just looking here where there's already a March listed. So I mean, somewhere we're off on.
Right. So as Sherry said, she's filling in for Priya, who is the director of HR at Laguna. And this is HR's report. So I don't know the detail. And Sherry, I don't know if you know or if you just inherited this while you're filling in. But I think we'll ask our HR colleagues to go back and clarify this.
All right, because that extends down to the other graphs, where each of the graphs come out showing a March point, and perhaps they all back up. I don't know, but I think we need to clarify what we're looking at in terms of the trends.
Yes, agreed.
I'm just wondering if Director Simon has comment in regards to the potential of staffing, especially in the city's budget issue, and that you feel that you've had sufficient input into anything that might have to occur as we are trying to, close, not us, but the city. And we therefore have to be part of that, closing part of that gap, and how Laguna feels that it's being supported or listened to, anyway, heard.
Yeah, yes, we are being supported. We are meeting regularly and able to work with the team in regards to to meet the required cuts, but to support and ensure that Laguna Honda has the staff it needs to move forward, to provide the care that's needed.
Okay, I think that's
We are
important.
involved and being heard.
Okay, because I think if there are issues that arise that then, let's say they knock out an administrator, they remove an administrator that you feel is really critical, I think that it's important that we are made aware of this in terms of it potentially, affecting our accreditation and standing with first of our Medi-Cal, of course, and then our Medicare potential. But I appreciate that you feel that you are being heard and that these are being taken under consideration.
Yes.
Okay,
Okay.
thank you. I have no other questions. Do you have any follow-ups? If not, then we'll go on to our next item, please.
The next item is the Regulatory Affairs Report.
Good evening, Commissioners. I'm Geraldine Mariano, Director of Regulatory Affairs. I will present the February 2024 Regulatory Affairs Report. For the facility reported incidents, there were 13 incidents reported and one anonymous complaint received in February. We had a total of 3 on-site visits with CDPH surveyors for February for abbreviated survey to investigate a total of 5 facility-reported incidents and 2 anonymous complaints. Please let me know if there's any question or comment that I can address at this time. Thank you.
Thank you. Is there public comment on this item?
Yes, surprisingly, there's still a hand up. Mr. Manette-Shaw, you've got 3 minutes.
This Regulatory Affairs Report for February being presented today is again shocking because it reports 3 site visits with on-site surveyors that happened during February, investigated 3 more anonymous complaints filed in January and February, and investigated 5 facility-reported incidents, 2 of which happened in December 2023, and the other 3 had been reported in February 2024. That's worrisome precisely because the 3 abbreviated complaint surveys involving anonymous complaints included in the matrix I presented during the executive team report today at agenda item number 4 resulted in LHH racking up another 17 citations against LHH after it was decertified 2 years ago in April 2022. These anonymous complaint surveys are bound to result in more citations against LHH. Worse, this report also acknowledges more privacy breaches and disease outbreaks. Why are there more probable infection control related disease outbreaks? Is LHH's new infection preventionists not doing their job properly? More worrisome, my year-over-year tracking report in Microsoft Excel I started shows that despite the $40 million in consultant costs following LHH's April 2022 decertification and after remedial corrective actions purportedly enacted from the so-called milestones implemented since April 2013, the Regulatory Affairs reports published following decertification reveal there have been 15 disease outbreak FRIs reported to CDPH, 11 major injuries, 57 other injuries of unknown source, 24 undescribed so-called adverse events, and 5 potential patient privacy breaches. For a combined total of 113 additional fairly serious facility-reported events, not just the run-of-the-mill patient-to-patient and staff-to-resident less serious abuse FRI allegations. Plus, since its April 2022 decertification, the regulatory reports have reported a staggering 67 anonymous complaints were filed with CDPH. If I can track this level of detail in a primitive Excel spreadsheet, why can't LHH's Quality Management Department provide this Health Commission with the same level of detail breakout that I've tracked? After all, I'm just a single old man with poor vision and no voice to speak with, no pun intended. Presumably, LHH's QM department has multiple LHH staff who could provide you with this data. Wake up, commissioners. Start asking meaningful questions about trends in this regulatory data, for God's sake. After all, if I can figure out and track these trends, you can bet your bibbies, rear ends, or asses that CMS and CDPH are way ahead of you and have probably figured this out already for themselves. That's why they're keeping such a tight leash on LHH and delaying resumption of admissions. Obviously, you ain't paying me much in comparison to SAG's $24 million in contracts, salaries you pay to Pickens, Baljeet Sungda, and Sandra Simon, or the salaries you pay to Dilter Sidhu and Jennifer Cartonway.
Your time is up, Mr. Manette-Shaw. Thank you. Right, that was the only public comment, commissioners.
Thank you. Commissioner Green?
Yes, I just wondered if you can comment more on all the facility-related incidents, reported incidents rather, that haven't even been begun, including things from over 2 years ago. I mean, I was just looking at this and, January of 2022, there were 19 they haven't started. Do we have any concerns? I mean, we've investigated these. So do we have any concerns that any of these could trigger another, 2567 or something that would delay us further? Or do we have confidence that we're pretty up to date and that the way we've interpreted these various incidences would not be interpreted in a different way by regulators?
Sure. I'll start, then I'll ask Naz and Geraldine and Sandra if you have comments. So particularly on the facility reported incidents, obviously we know about them because we report them. So when we do that, we immediately start our investigation and or corrective action process. So, and if we were to ever find something that we thought would be a threat to regulatory compliance or certification, we would definitely jump right on that. Obviously, in terms of the anonymous complaints, we don't even find out about those until they actually show up on site. But again, once we are aware, we immediately go into investigation and action plan mode. And at this point, we're not aware of anything that has risen to the level that would cause us pause in terms of our ability to proceed on the path that we're already on towards recertification.
And do we have any sense for whether anonymous complaints are investigated faster than facility-related incidents? In other words, have we obviously haven't had that. Well, we have had some they've investigated. Is there any sense based on history of, whether they're prioritized or how quickly? In other words, there's still, I don't think we have it divided up here, but I wonder, if the anonymous, well, they're here actually, but, we've got several for 2023. And I'm just wondering, it looks like there are 20 pendings and four that investigations haven't started for 2023. So, I mean,
I can say a little bit about it, but Naz is the expert and has more of the details. I do know that CDPH does prioritize particularly complaints that result in either abuse and or harm, and that they will prioritize those over other instances. But I'll let Naz kind of give you more of the details.
Well, and that's correct. So generally, the CDPH will come out and cite much quicker for anonymous complaints. But that doesn't mean when they come on site that they close the case right away. So as you'll see in the graph, right, generally all anonymous complaints have been investigated, but we still might not know the outcome for some if they did not give us a verbal exit after their review. We wouldn't know about the anonymous complaint unless they notified us.
Mm-hmm. All right, thank you. Well, there's very few of them here actually where investigation not started, but having heard earlier today about these 2567s, I just was curious how we were going to manage if something came up, or whether we have confidence that if any of these left over from 2023 were really significant, they would have been out. I mean, God knows they've been out a lot. So they at least would have received and reviewed them, and hopefully it would have been part of their immediate response. And I gather that's kind of been your experience.
Yes.
Great, thank you.
I'm just looking at the chart here, and could you go over on the 2023 anonymous complaints what each of the blocks actually mean? Like, there's 22 in, it's a little hard to read all the colors because of the way that it's been punched in, but maybe you could just carry us through how the 2023 complaints equal, like there's 22 and there's 18 and there's 40.
Yes. The 22 in blue are where we have indication of no deficiency, so an outcome has been provided. The 18 in gray are pending for a total of 40 cases, 40 anonymous complaints in 23.
So the top bar is the total. Is that
That's
what
correct.
we're?
Yes.
Okay.
Yes, and I apologize because we're sharing with you, shout out to my data team who did bring this up. This graph is getting very tight because we want to continue to share with you all how far back the open cases go. which as you can see, we still go to 2019. So it's making this very tight. We're trying to think of a way to make it easier to read it more simply. So we do apologize.
Okay, so the top blue actually needs to be kind of read separately because it is not a cumulative sum.
Looks like there's 6 from 22 and earlier that are yellow, which means they haven't been investigated yet. 6 anonymous complaints. 'Cause
Where is that?
so yellow is anonymous complaints. So this is 2022. There's 4 there. Yellow means not investigated.
Okay.
There's-
Right. Oh, yeah, I see the 4s over there. And then the top bar is actually, so if we wanted to follow the total, we follow this top bar. And
the far
otherwise,
right are all the removed. This is anonymous.
yes. Right. And which of course it does show that they've actually, for the most part, they're just missing those 4, which is sort of interesting. But perhaps as an anonymous complaint, they weren't of that serious nature, I guess, in 2022, because that goes way back.
Yes, and it's very possible there's the rare instance they will call Geraldine or someone and say, we have an anonymous complaint and we'll, check in later about documents, but we'll also go back and double check our tracker. That is a rarity that they will, back in the day, give us a heads up and then we're waiting for their follow-up.
You actually still have even one back to 2020. I guess our concern isn't the way that they manage it, but how, since Mr. Pickens noted that they could come and then create a new deficiency, that we are still trying to figure out whether some of these that they haven't opened, whether we're counting correctly or not, right? Because
Correct,
it's
yes.
kind of hard to think that they have something in 2020 that's still pending on that.
Let alone 2019. Not for the anonymous, for the open cases that we've reported.
Right. Okay, well, thank you for telling me what all the top bar is, because
No
I
problem.
couldn't get
We will-
things to
You might
add
see a
up.
different version next month, just to make it easier on the eyes.
Yeah, I think what you might do, because what we were looking for is the volume
Right.
of the fries, is you could use that as just a line graph coming across,
Okay.
so that the bars are correct in terms of volume,
Mhm.
and the line graph tells us the trend as to how many there are.
Okay.
And that would really help a lot if that's not a lot of extra work.
No, we'd be happy to do that. Easy enough.
Okay, all right, thank you.
Thank you.
So I guess we should note that, in fact, if the numbers are correct, they have fallen to single digits in the vacancies and in the nursing staff. So I do, we continue to commend the HR department. I know that general, we got a very good report too, compared to the past, and sounds like the system may be working for all of us. So thank you. I have no other questions unless you have any further. We'll move on to our next item, please.
Sure. Item 7 is Laguna Honda Hospital policies, and the proposed action is that you all would recommend to the full commission approval of these.
Okay, so who's presenting those?
Carmen is going to present.
Presenting. Hi, good evening, commissioners. I have 9 policies for approval today. 5 of them are hospital-wide, and they're all revisions. The first one is 23-03, screening and response to suicidal ideation. 24-08, off-campus appointments or activities. 24-22, code green protocols. I also wanted to highlight there were 2 additional revisions after receiving questions and feedback. On page 18, we added 2418 resident locator system policy to the reference section. And we also updated the premises to include Laguna Honda property on page 5. The next policy is 70-01, C1 fire response, 71-01 fire safety program. There were 4 departmental policies, 4 revisions for the nursing department. The first one is acute A02.0 documentation of care, acute unit, D6 1.1 battery operated lift transfer, J 8.0 blood transfusion, and M 12.0 adaptive assisted device management. And those are the 9 requesting for approval today.
Oh, fine, thank you. Commissioner Green, oh no, is there public testimony first on this?
I don't see a hand. I just want to make sure everyone knows we're on item 7. Caller, if you'd like to make a public comment, please raise your hand now. I see no hand.
Okay. Commissioner Green.
Yes, well, I appreciate the written responses. And it sounds like the questions I had were well answered. So I don't have any others really. Thank you.
Okay, so then I will go to the question of the blood transfusions. And I guess Director Simon might be the one to best answer this in the fact that since the explanation given back to us is, well, the problem is that there are some people with chronic blood transfusions, and your policy seems to say that if they're basically stable patients with chronic transfusions, which we previously, I think, did on the wards, that this no longer is possible, nor is it possible to transfer to the acute unit that does transfusions unless you qualify as an acute patient. So patients like with thalassemia or a sickle cell, I suppose, or some other chronic anemia that requires a periodic transfusion would then seemingly require a transfer out in order to do it. So it sounds a little traumatic to a patient too, who with our fine facility might be able really to get that blood transfusion without being transported back and forth. So I'm asking, I guess, one, is policy prohibiting us to give to give transfusions, and which is really sort of unfortunate because it then creates a sort of a less than desirable transfer for just simply a blood transfusion.
So I'm not sure I understand. Is the question that we can know, because you
The,
can't,
the policy seemed to say that you cannot give a blood transfusion to somebody who has chronic anemia that might require a blood transfusion, which we used to do.
Well,
out there.
if I may jump in, so the policy states, if I understand it correctly, that a resident has to be transferred to the Laguna Honda acute unit or to an outside in order to get a transfusion. Commissioner Chow's noting the complexities of many patients who might need chronic transfusions and asking, how does that work if, like, for instance, the acute ward is full? Or, I think that's the practicality of what he's.
the acute ward is,
Well, first of all, if it is a chronic stable patient, then they don't really qualify to go into an acute ward as a acute admission because they're not really needing an acute admission, right? And in the past, you had this come and go process, which allowed then rather than on the ward, because I remember we decided on the ward was not a good idea. So we did use the acute unit in order to deliver this transfusion to somebody who's stable, but does need the periodic transfusions. So according to this policy, since you're not doing it on the ward and we really have to follow rules for acute admission, and we're not allowing that to be used as a come and go, then it would sound like the chronic anemic patient would need to be transferred out, which seems to me maybe bureaucracy requires that, but it's not really in the best interests of a patient because the transfer out is by itself sort of a disruptive, move in order just to get the blood transfusion.
And just noting that Dr. Lamb is there in case you're.
I saw, Dr. Lamb, can you speak from a physician perspective?
Yeah, definitely appreciate the commissioner's question, and we agree that we see the added difficulty in needing to transfer someone out who is not appropriate for acute admission to our general acute just for an infusion. However, we are not licensed as an infusion clinic, so we are unable to accommodate those residents at this time.
Are we intending to consider being licensed as a transfusion site?
Uh, There are discussions, and I think that that would certainly be something that would be an added convenience. It would be great to have that for our residents. We have several major hurdles that we'd like to clear before picking that up again.
Okay, well, rather than having it be sunk into the abyss of something we'll think of later, I'm wondering if that can be brought back at some point in time as we are reviewing policies and perhaps as an update. Because I do think that if we're able to do that, and I thank Dr. Lamb for giving us the ability to do it if we are a transfusion, center, but if you can also then demonstrate that this doesn't really work for us, then there may be a need to not do it, I guess. But I appreciate that you're looking at trying to do it because it's something I think that would be helpful for patients. I mean, there are not a lot of them, so I recognize that. Well, there might be. We have quite a few very chronically ill patients. So, so a follow-up would be nice. In terms of where we are, if maybe 6 months from now or something. I'm assuming that we'll have become Medicare certified by that point, so we could look at that. I understand at this point it's probably not appropriate to look at, but would be good. Commissioner Green had a follow-up question.
Yes, I'd be curious to know how many residents this involves. And another thing that I'd be also very curious about, we have chronic iron deficiency in pregnant women. And, I wonder the extent to which the population has anemia of chronic disease, which means they just have to be transfused because there's no other option. And how many people actually have an iron deficiency anemia, maybe from chronic gastritis or GI loss or whatever, because those people can be given Venifer. It's an injection. It takes like 20 minutes, and that may preempt the need for transfusion. And when people are 2 to 3 grams low, if they're taking oral iron, and again, oral iron, you can only absorb 5 milligrams a day, it can take 200 to 300 days to make a dent. So I'd be curious to know, and this I realize is a medical question, but since this came up, I'd be very interested to know whether, in this subpopulation, what their ferritin levels are and, what's being done. There's a right way and a wrong way to take iron. It's usually ferrous gluconate at bedtime with chewable vitamin C. It absorbs better. There's a whole, but I know all of this because of this constant issue with women whose iron obviously drains by pregnancy. But I'd be very interested in knowing whether there are some kind of preemptive measures such as those that we can take to avoid the need for transfusions. And maybe they're all anemia of chronic disease and it's not going to help. But if there is an iron deficiency component, I think it's very worthwhile being proactive. And it's only been very recently, actually, that we've been able to have a form of iron that isn't a 3-hour drip that's difficult. But, for us, just a push, and that's all Venifer is, it might be worth considering. I'd be happy to share what we know, offline, if that would be of interest.
Yes, please.
So commissioners, after recertification is achieved, I'll note myself to prompt Laguna Honda to, that we'll put this on the schedule. Sounds like a whole update on these issues, but that will come, as we said, after recertification and anything else that relates to it.
Right, and I think Commissioner Green brings up a good point to try to find, what the volume is that we're really dealing with. Because if the volume is really minimal, then we could understand, not going through the hoops of becoming a transfusion center. But if it's, a number of chronic illnesses that require that, then it would be something that we would like to encourage. Okay. Are there further questions on the policies and procedures? And if not, then a motion for some recommendation to the commission would be in order.
I move that we recommend approval of these policies and procedures to the commission at large.
And I would second that. So we'll take a vote. All those in favor, please say aye.
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 Great. Thank you so much. And thank you, Carmen. Let's move on to item 8, consideration for closed session. Is there public comment on this item? I see no hands.
Okay, so a motion is in order for a closed session.
Move to go to closed session.
I would second that.
All those in favor?
Say aye. Yeah.
All right, please give me 30 seconds before we go over. So we're still live until I say we are off. You're back in open session. Commissioners, please consider a motion to disclose or not disclose discussions held in closed session.
Move not to disclose.
I would second that.
All those in favor?
Aye.
All right, thank you. And then finally, a consideration for adjournment.
Move to adjourn.
And I would second that.
All those in favor?
Aye.
Okay, great. Thank you. Give me 10 seconds to close us out. And thank you everyone for attending, writing comment, and all the staff. And let's see, we are